Uh, another- hello, everyone. Welcome to another virtual morning report. Uh, I'm excited to be discussing a case with one and only Dr. Ravi. Uh, and we have with us Eugene, who will be presenting the case. Welcome, Eugene. Do you want to share a few words?
Yeah, thank you very much, Vijay. So my name is Eugene. I'm a medical officer from Ghana, and I'm very excited to be presenting this case to Dr. Ravi and then Vijay. Dr. Ravi is a very wonderful teacher, and I've really been enjoying his teachings, his schemas, the website that he has. There's a confession. I actually go to that website whenever I need to quickly do some rapid review or have some medical students that I want to teach. I just go there and then just pick some schemas and then use them to teach them. So that's just a confession I want to make out here. So yeah, I'm excited to present this wonderful case to you guys and everybody else in the chat. Thank you.
Wonderful. We have with us Dr. Rahul, who will be scribing, and Minahil, who will be doing teaching points. We can have a few words and then we can get started whenever you guys are ready.
Hello, hi, I'm Rahul. I'm an incoming PGY1 into the AIL Waterville Internal Medicine Residency Program. I'm very excited for Dr. Ravi's and Vijay's discussion, and I hope I'm going to learn a lot from Eugene's case today. Thank you.
Hello everyone, I am Minahil. I am incoming intern at Corwell Health Dearborn, and I am very much excited for Eugene's case and Dr. Ravi and Vijay's discussion. So looking forward to the case.
Yeah, and I'll just chime in. I'm just very excited just hearing incoming intern, the words. It's just amazing, so powerful that we have so many people that will start in July as interns in various communities and add to the health and welfare of surrounding communities in the US. And I just hope you take all the learning that you've had from CPS and then add it to these wonderful institutions that you're entering. And thank you, Eugene, for those very kind words. Yeah, I actually look at my own graphics when I'm going to teach people as well, and then also Rabi's graphics and CPS and so on. So it makes for wonderful reference material on the fly to teach people. So really appreciate those kind words. And I guess we'll get started with the first aliquot. Over to you, Eugene.
Okay, great. So we're going to take off with the first aliquot. Okay, so we have a 42-year-old woman who reported that she has bilateral lower limb swelling over the past 2 months and abdominal distension as well. And I'll pause there to hear her thoughts.
Yeah, I think it's a wonderful chief concern that is fairly common. So what is very concerning is where is the site of the scene where we are going to get clues to what could be the possible cause. So the patient has noticed lower limbs, just clarifying. So did the patient notice the abdominal swelling initially and then the lower limb swelling, or was it the other way around? I think you're muted, my friend.
Yeah, so the lower limb swelling began first, and then she noticed the abdominal distension.
Okay, so it's been very useful. So the common three things whenever we see bilateral lower limb swelling. So three common disorders: cardiac, liver, and renal. So this is a common thing that I think of. Other thing that I keep in mind is drugs, so especially like gabapentin or pregabalin and drugs like amlodipine, so commonly used drugs. And given that, so these are the common, and I'm assuming there is no significant pain here, bilateral swelling, and the patient is also developing subsequently an abdominal distension. So the common cause for abdominal distension, whether it is air, fluid, or a solid structure that is enlarged. So the presence of abdominal distension makes me think the lesion to be probably it is liver related, or it could be cardiac related. So both things are possible. So it is too early to latch upon any significant particular diagnosis here at this point. But I would favor possibility of a liver disease. So I would be curious to know more. However, one excluding factor or one caveat here would be a long-standing constrictive pericarditis, like a pericardial disease that could present usually with ascites and then liver lower limb swelling. So that is termed as like ascites precox. But I think that is also one thing that we have to keep in mind. So all three could be possible. So I'm just curious to know the associated symptoms and how it goes.
I think that's a wonderful start, Vijay. I think, yeah, when we try and think of what could be causing this, we want to make it simple, right? We say keep it simple. So you just focused in on the various organs that could be responsible for, essentially, we're talking about right-sided congestion, right? So going from the heart and going down the venous complex, right? You may have congestion in the peritoneum, ascites. You may have congestion within the legs, so bilateral lower extremity edema. So anywhere along that pathway, that anatomical pathway, there could be pathology which could compound this. So at this point, I think we can also dive into the physiological processes and the delicate balance between hydrostatic and oncotic pressure, volume overload, and so on. So all of this I actually have around it this morning and had several cases regarding this. But it's interesting. I've had patients come like this, and we have no past medical history of cardiac disease, renal disease, liver disease. So our job will be to investigate these areas and looking for signal to hone in on, and then make progress as to what's causing this presentation here. But I also would like to know symptomatically, like what has the patient been doing all this time? Has the patient been maybe immobilized for a while? Is there history of maybe a prothrombotic risk? Because I've had patients, actually, it's very rare to have bilateral lower extremity DVTs. It wouldn't explain the ascites though, but you could have a thrombus within the IVC maybe causing something like this. So we're kind of getting into the realm of esoteria, but I would roll it back to what you mentioned, look in those three domains and see if there's signal there. The next few aliquots actually might shed light on this. So I'll turn the mic back over to Eugene. Eugene, next aliquot, please.
Yeah, that was an explosive start. And yeah, so I'll give you what you asked for. So here's a 42-year-old woman who reported that her symptoms began 2 months prior with progressive abdominal distension, bilateral leg swelling as indicated. But approximately about a month ago, she visited a peripheral outpatient clinic where she did a chest x-ray and other labs. And then she was informed that she had an enlarged heart and then was prescribed some medications. But at the time, she felt her symptoms were mild, so she discontinued the medications after a week and then resorted to unspecified herbal preparations. Over the following weeks, her condition worsened with the development of upper limb swelling, increasing breathlessness, early satiety, and further abdominal distension. So we asked her some questions. So on the diary questioning, she had autopnea, she had some palpitations, she had reduced exercise tolerance. She had intermittent cough with pinkish sputum production. She also had right hypochondriac pain and early morning facial puffiness. She, however, didn't report of any chest pain, paroxysmal nocturnal dyspnea, syncopal attacks, no fever, and then no recent travels. I'll pause here for us to discuss, and then I move on with the next arguments.
So I'll sort of make a few comments, and then Vijay, if you want to then elaborate on that. So it looks like this has been developing for about a month time. And then there was this description of heart is enlarged. So immediately antennas go up. Is this all stemming from the heart? Left-sided, right-sided heart failure. But you also have to wonder about what's in between, which is the pulmonary vascular system. So are we thinking of pulmonary artery hypertension? We're still kind of premature because I think this thought will reflexively result in an echo or getting the hemodynamics for this enlarged heart that was proposed in this second aliquot. You know what's interesting? Like the orthopnea, palpitations, cough, PND, immediately in medical school, we always teach this as having a high likelihood for congestive heart failure. However, there can be causes that may cause this pseudo sort of like heart failure complex here. So are we actually dealing with heart failure? Maybe. I mean, this definitely has a good likelihood ratio, JVP, on exam, hepatojugular reflex, orthopnea, PND, we always think about, but I think we still need to be careful we don't fall, or it could be a pitfall where we actually could go down a very deep rabbit hole and miss this complex of could it be pulmonary arterial hypertension, something along those lines. But I'll turn the mic over to you to see what else you can sort of squeeze out from this aliquot.
Yeah, I think I don't have, it doesn't scream out much apart from the same things. So pretest probability of heart failure, maybe right or left being is higher. I'm just trying to see if we have any clues to say what or why did the patient have this at this point of time. So are we getting any clues? I'm not really sure. But all these symptoms scream of a right-sided disease, so right heart failure. Like patient is significantly congested. So very important is to not miss a primary pulmonary hypertension at this age. Very commonly missed. So, and especially a congenital heart disease like a shunt, pre-tricuspid shunts, like an ASD. So those could be presenting at this age with a heart failure. So that is one more thing that I'm thinking of. So majorly the heart, and so I'm just curious to know if there are any clues to maybe the history, or maybe on evaluation we'll get some more clues to what could it be. So pericardium, myocardium. So we can just narrow in on after we get some more clues or some more evaluation for this. One thing that is screaming out is the presence of this pink frothy sputum as well. So maybe there is component of both that are being involved. So maybe both disease process that is involved. So maybe an old standing myocarditis. I'm not really sure. So what is the etiology? So maybe we'll find out subsequently. So over to you, my friend.
Those are great thoughts. But I have a question. What do you make of the early morning facial puffiness?
Yeah, actually, there's a lot of components to this. I kind of missed it. So, you know what's interesting is puffiness. Puffiness as a whole, there's certain things that cause puffiness, right? Especially if it's symmetric. So certain things come to mind. Nephrotic syndrome, you know, is probably a well-known cause of it. And SVC syndrome could cause puffiness, Cushing syndrome. Then you go into the endocrinological causes, right? Cushing syndrome, you can have that myxedema coma. I've seen facial puffiness. But with this early morning, I think it is a vascular issue with the pressures increasing. When you're lying flat, like you get orthopnea, this distribution. Now I'm kind of thinking, could this be a nephrotic syndrome? Because you're kind of describing this anasarchic-like picture, right? Legs, abdomen, up into the chest. And one key feature with, say, just low albumin, total body anasarca, by the evening, all the fluid kind of settles to the back. So when you look at the patient's back, the whole back, there's like, when you palpate the skin, it's all kind of mushy. And the lowest area where this mushiness in the skin, excuse my non-technical terms, but it's usually in the sacrum. You'll see sort of a accumulation of congestion there. And also you have the ascites and so on. So anasarca, definitely the skin becomes very swollen, and long-standing anasarca will lead to the fluid moving through the skin. It will follow the path of least resistance. The tension rises, and you see the fluid sort of furrowing through the skin and causing edema bullae, we call it. And when you have ICU, I think you Vijay, you've probably seen what we call these coma bullae, right? So patients in ICU, low oncotic pressure, malnourished, vented. On the bottom, you see this coma bullae forming, right? Because the fluid is tracking, and then it's burrowing through the skin and causing this bullae, sort of something like that. What are your thoughts about this? Look, but getting back to the face, any Is there anything that you can sort of squeeze out of from this finding?
Although, like, we think classically for a renal disease or nephrotic syndrome as a classical association, so I think I'll just keep that in the back of my mind. I don't think there is a very strong signal to prioritize one over the other here, because we have features of a mix of everything. So maybe severe congestion itself or high mean systemic pressures itself could cause all of these symptoms. So I would not put in a lot of weight on this, but I would just definitely keep it in the back of my mind while evaluating, not to miss out a renal cause. Especially spinning the urine would be very essential, because we could also have a chronic congestion leading to like a cardiorenal phenomenon or renocardial phenomenon. So that complex interplay that would be there. So apart from that, I don't think I find something screaming out at this point of time.
Wonderful. Back to you, Eugene, for the next aliquot.
Those are very wonderful discussions. So in the next aliquot, I'll review the past medical history, the drug, social, and family history. So yeah, in the past medical history, she actually developed gestational hypertension 11 months ago. That was during her most recent pregnancy. That it didn't progress to eclampsia or preeclampsia. And she had an uncomplicated SVD. Postpartum blood pressures, the readings when checked occasionally, she mentioned was between 130 to the 140s and then 80s to 90s. She had no history of chronic hypertension prior to this last pregnancy, but she reports that she's had a history of gestational hypertension in her previous pregnancies. She's grabbed a 5/5. There's no history of diabetes, there's no history of chronic kidney disease, there's no history of liver disease, and there's no history of asthma. In her drug history, she was given metal-dopa for gestational hypertension, which she was compliant to, but discontinued after delivery. She then was given lisinopril and furosemide at a peripheral clinic. If you remember, she went to a peripheral clinic 1 month ago where she was told she had an enlarged heart. She was given lisinopril and furosemide over there. But she discontinued those medications when she perceived she felt better and actually went to start on unspecified herbal preparations. She has no known allergies. In her social history, she sells secondhand clothes. She's married with 5 children. She denies alcohol and smoking use. For family history, there's no known family history of chronic illnesses. And I'll pause here for us to discuss a bit.
Vijay, you want to start with this?
Yeah. So I think there is 2 things that are striking in the past medical history that are giving us some clues. So this patient is gravida 5 and para 5. And every pregnancy has had a diagnosis of gestational hypertension. And we know that a small subset of, I'm not sure the percentage of people who develop subsequent frank systemic hypertension later on, but it does pose a risk of systemic hypertension. So given that multiple episodes of this has been there and the compliance of drugs has been, and patient has not been able to completely be compliant with the medication. So I'm thinking, is there a long-standing chronic hypertension that has caused the patient to suddenly decompensate? And also the patient has also been told that the patient has an enlarged cardiac silhouette on the chest radiograph. So maybe that is giving us a clue of some long-standing disease, probably cardiac. This is just favoring one of the cardiac disease here. But apart from that, what is it helping is there is no significant exposures or smoking and alcohol is not there. So there is nothing strongly that is, it helps out lower as secondary causes. So only thing strongly striking is the hypertension. Apart from this, because pregnancy, multiple pregnancy episodes, so one is peripartum cardiomyopathies, maybe undiagnosed and maybe long-standing, and so that is one more thing that is there in the back of my mind. Because when I'm thinking of a cardiac disease in a young person, so mostly it is muscle related or a vessel or vascular related rather than a coronary artery related. So these are 2 things that is strongly there in the back of my mind. So these are my thoughts. Any thoughts? What are your thoughts, Ravi?
Yeah, absolutely. I'm going to kind of piggyback off what you've mentioned, and I think is very relevant. There are 2 complexes here, which could be the cause of this presentation. What one, you did a great description of the peripartum conditions, this high blood pressure, and I'm going to kind of talk about the high blood pressure, even at 42 years of age, I do see quite a bit of our patient population with HFpEF. So I guess here, what will really make progress is getting an echo, get the hemodynamics like we talked about. We talked about pulmonary artery hypertension. You talked about idiopathic class 1. How about thinking about class 2? I don't get a signal here of any pulmonary issues yet, but I think it's worth investigating echo, and then from that you could probably calculate the H2 PEF score. And in the H2 PEF score, we look at certain parameters, and then you calculate, I think, greater than or equal to 6, you have a likelihood of HFpEF. But within 2 to 5, the score, it could be HFpEF. So definitely diagnosing HFpEF, and then wondering, the HFpEF is secondary to underlying disorder. What is that underlying disorder? I'm not sure, but I think in one of our academy sessions, or somebody had talked about amyloidosis, and I think Ravi had maybe talked about amyloidosis, that 1 in 8 or 10 patients may have amyloidosis causing HFpEF. And nowadays we do have a treatment for this, which is tafamidis. There can be ATTR, there can be AL as well, which will have a different, you have to refer that AL amyloidosis patient to hematology. But I think here what really will help, yes, of course, the exam will help to figure out, is the heart at the center of this problem, and then getting an echo. And if the heart is giving a signal for this, definitely an echo will help at this point. Anything else, Vijay, before we go on to the physical exam?
Nothing else, Ravi. Over to you, Eugene.
Amazing. So I'll give us the physical exams. So the physical exam, I'll start with the vitals. The blood pressure was 156/89. Pulse was 112 beats per minute, was regular. It later settled to 90 beats per minute. Respiratory rate was 22 cycles per minute, sorry. And temperature was 36.3 degrees Celsius. SpO2 was 98% on room air. General appearance, she appeared very ill. She was sitting up in the bed. She was afebrile. She was in some form of respiratory distress. We saw that she was flaring the LNAC. She had patent edema of both legs up to the thigh level. She
Oh, I thought I was having internet issues, but it looks like Eugene has frozen, so we can wait for him to log. Okay, he logged off. He'll log back in. So far with this exam, let's see what we can sort of squeeze out from this these vital signs. What do you think, Vijay? Anything?
Yeah, I think so. Our greatest suspicion of patient having a chronic hypertension. So the patient is significantly having a hypertension. And apart from this, I'm not seeing anything. So maybe the heart rate is on the higher side. So I'm just thinking this the patient having some heart failure. So so we don't expect this amount of high BP in a decompensated heart failure. So maybe the patient is having some occult heart failure because the heart rate is higher. So the heart is compensating by increasing the heart rate. Patient is ill, so probably I'm thinking that the patient is decompensated. And the systemic examination, I think the pitting edema up to the thigh. So all that I'm seeing is some volume overload. So I'm just curious to know if the exam is showing any cardiac murmurs or gallop rhythms or elevated JVP. So I'm just looking at that. Apart from that, very interesting that if we are thinking that the patient is in heart failure, but somehow the respiratory rate is maybe little on the higher side. So all of that is saying the patient is having some amount of respiratory distress.
Awesome job, Vijay. Yeah, I totally agree that definitely we've set the stage, blood pressure is high, and Eugene is back to shed some more light on this exam. Eugene,
Yeah.
please feel free to take it away.
Sure. Sorry about that. So I'm back. So yeah, so she was basically having an Osaka. That's what I would say. In the cardiovascular exams, we had raised JVP. The heart sounds were present, 1 and 2. There was S3 gallop. There was a pansystolic member at the mitral area. And the apex beat was displaced to the SID intercostal space, anterior axillary line. On the respiratory exams, she had decreased air entry at right, middle, and lower zones. She had caused crepitations bilaterally in both lower lung zones. On abdominal examination, the abdomen was grossly distended. It was shiny and tense. There was positive fluid trail and shifting dullness, mild tenderness at the right hypochondrium. The liver was palpable about 3 cm below the costal margin. There was no splenomegaly or palatable kidneys. The CNS, she was conscious and alert. There were no focal neurologic deficits. I also give us some labs, or maybe I could pause here for us to deliberate on the examination findings. You can let me know.
Awesome. So just to add to Vijay's wonderful analysis of the vital signs, yes, the blood pressure, the heart rate, 112, I agree, patient is tachy, but heart failure is a sympathetic process. You will have a sympathetic discharge and then tachycardia. There is this whole, if you read about heart failure, it is this whole neurohumoral complex that happens with all the different all these different hormones being released, and you may have a sympathetic discharge with tachycardia, which will further exacerbate the heart failure because ventricular filling is then compromised because of that. So that's why beta blockers are key in HEF-REF, but here we're anticipating HEF-PEF, so beta blockers probably won't have as much evidence for use. But the abdominal distension, there is a fluid thrill. This is anosarca. This is ascites, because abdominal distension could be many things. It could be air in the colon. There could be stool. There could be mass, hepatomegaly. So you always want to ascertain when you have abdominal distension, is it actually fluid that we're dealing with, or are we dealing with some other reason for this abdominal distension? At this point, I think this is massive anosarca. You don't usually get with heart failure. I've never seen just full body anosarca for quite some time, unless you allow it to progress. Usually by the time the patient presents, especially if it's left-sided heart failure, HFpEF, HFrEF, they will have pulmonary edema. That will bring them to the emergency room. This is sort of a slow rise in the fluid building on the right systemic vascular side without the patient really now having maybe overt pulmonary edema. What do you think, Vijay? It's taken some time. It doesn't just build overnight, right?
I think I totally agree with whatever you have said. So this degree of anasarca, so I think the heart has to be long-standing and has to be pretty severe, that the patient has not sought much of medical care because patient has intermittent. So, or probably patient took some medications intermittently when the symptoms worsened, and then once she felt better, maybe she stopped the medication. That is one more thing I'm just thinking of. Other thing very curious on the examination is this amount of this narrowing on the physical exam. Just to say, I think there was a pansystolic murmur in the mitral area and an S3 gallop. So all that is saying is probably two things it says. There's definitely a volume overload and the severity of lesion. So probably the presence of S3 is saying the mitral regurgitation. Probably there's a mitral regurgitation and it is pretty severe. So that is what I just analyzed based on the physical exam per se. And definitely there is, you are having both signs of, and this has to be long-standing because we have a right heart failure as well with significant congestion. This anasarca, so I wouldn't, so like we already discussed, I wouldn't throw off the renal disease. We could have some diseases that could worsen. So some nephrotic syndromes, especially. So they can worsen with pregnancy, or they may become manifest during pregnancy. So that is one more thing that that is just in the back of my mind. So one is a mitral valve disease, so maybe a coexist, and one is the epidemiology of where the patient is coming from. If there is a significant rheumatic heart disease like in India or the place Africa, I would just keep that also in the back of my mind, because most of the patients don't really underappreciate the symptoms, and unless and until they have a frank decompensation, they do not visit medical care. So that is also in the back of my mind. So that is one of the etiology. So these are my thoughts.
Yeah, absolutely wonderful. Yeah, I think just sort of doing a journey through the heart and which junction in the heart anatomically could be causing this. So definitely more information, especially this, I keep mentioning this echo. But what was interesting with this, a patient like this, I think also while we try and solve the problem, I think trying to decongest this patient will bring relief to this patient immediately. However, if there is hypoalbuminemia present in this patient, it's just going to be very, very difficult, because as soon as you evacuate fluid, there will be more fluid translocating and taking over that space again. So I kind of hope that isn't the sort of presentation here. Like to definitely get a pro-BNP, get an albumin, and get an echo, and then see what we have then. Over to you, Eugene, for labs.
Amazing. So yeah, I'll give us the labs right away. But I'll also remind us that this patient saturation was 98%. In fact, one of the amazing pearls of this case is the fact that the patient had all this fluid overload, but did not look overtly in respiratory distress. So I'll just jump onto the labs. So for the complete blood count, HB was 9.8. The HCT was 28.6, slightly low. MCV was also slightly low, 51.2. MCH was 19.4. The white cell count was normal at 7.7. However, the neutrophils was about 83.4%, slightly neutrophilic predominant. And the platelets was 149. We did ESR, it was 39. We did a liver function test. ALP was 121, GGT was 47, AST was 20.2, ALT was 23.3, albumin was slightly low, 26.7, and T-bill was 0.80. Direct bilirubin was also 2.8. These were all normal. We also did a renal function test. Urea was 20.8, creatinine was 1.37, sodium was 134, potassium was 3.9, and chloride was 96.4. We had a previous renal function test, which was about 9 months ago, and there was not much significant differences between these two. We did a urinalysis as well, and with microscopy, we had a 1+ proteinuria. Blood was negative, leukocytes were negative, nitrites were negative. There were no cast, normal red blood cells, and there were few epithelial cells. We also did a BNP. We don't have full BNP, but we did a BNP, which was 2460. That was very, very high. We also did lipid profile. Total cholesterol, LDL, HDL, triglycerides were all normal. We also did the troponins, which were normal, troponin C and troponin I. We did HbA1c, which was 5.3%. And we did the urine protein creatinine ratio based on the proteinuria and the urinalysis. We had 0.9 gram per grams, which was mild. Then we did some imaging. A repeat chest X-ray showed the cardiomegaly. There was massive right pleural effusion, which the level was at the right side, and then we reduced it with a chest tube drainage immediately. We also did a pleural fluid analysis. It was translated. There was stroke alert, protein was 1.5, LDH was 100, glucose was 90, pH was 7.45. So just a translated picture. We also did an abdominal ultrasound. It showed bilateral chronic kidney changes, hepatomegaly, dilated hepatic veins. There was more, the ascites was moderate on the ultrasound. IBC was minimally collapsible. The gallbladder wall was slightly thickened. We did a serum ascites albumin gradient. It was 1.3 gram per deciliters, which was also suggestive of translucent effusion. Then we did ECG. So that I will share my screen and show us the ECG shortly.
Okay, so quite a bit of data there. I'll start off with the CBC there. So there is, for a 42-year-old, there's anemia, mild thrombocytopenia. So you could say there's a bicytopenia there. And okay, we'll stop for the EKG. Let's have a look here. Anything jump out, VJ?
Nothing grossly jumping out. I think, not sure, V6 has a different kind of a morphology of T waves. Apart from that, I think there is some flattening. I think I see like lead 2, lead 3, lead AVF. I think there are significant T wave inversions as well in those leads, especially in the inferior leads. I think we have electrolytes. I think sodium by potassium, I think is little on the lower side. Maybe that is one thing that I keep in my mind. Apart from that, but maybe some slight maybe left atrial enlargement. So on the V1, I think this Morris
V1,
index that
yeah.
we call it. So that is the only thing that is jumping out. Apart from that, voltages are fairly preserved in both the limb leads and the chest leads as well. So these are the things that I'm seeing. Anything
Yeah.
jumping?
A lot of kind of, sometimes we can call it non-specific stuff. I like that Eugene has blanked out the read, the computer read there, because sometimes that can influence it. But nothing major here. I'm not, let me see, quick S1, Q3, T3, I'm not seeing there. I did, you know what's interesting, this patient, Eugene, you mentioning, I did have a patient with a chronic pulmonary embolism causing right-sided congestion. And my whole analysis of the case was this is congestive heart failure. But then somewhere along the line, we're like, the pulmonary vessels are involved, and chronic PE actually was the diagnosis. And his EKG did show S1Q3T3, right axis, right axis deviation, right bone debranche block, and also right atrial enlargement. So all the complexes were directing towards the right side. I'm not seeing anything like that. We're not seeing any, I mean, could there be ischemic injury, the ST depressions, V1, V2, and then three AVF lead 2. I would like to compare it to an old one if these are new or these are chronic for this patient, but nothing that I immediately need to jump into action. No STEMI here that we could see, or no right-sided complexes to suggest like a PE.
Great. Yeah, so I'll continue the case. So yeah, the EKG got us the more confused, non-specific T wave inversions, V2 to V3. We didn't really find any signs of pulmonary embolism, and we unfortunately didn't have a previous EKG. So I'll give us the echo findings. We went ahead to do echo. The echo showed ejection fraction of 23%. That was severe systolic dysfunction. There was moderate mitral regurgitation. There was moderate pulmonary hypertension. The pulmonary arterial systolic pressure was between 50 and 60. And then there was mild pericardial effusion. There was no intracardiac thrombus seen. We also did some other labs based on the clinical picture. We went ahead to do ANA. The ANA was positive, but the titers were low at 45. We did complement 3 and complement 4, which were all normal. We did anti-DS-DNA based on the positive ANA, and that was negative. We did lipid profiles, they were all normal. We did thyroid function tests, they were all normal. We did the serologies as well, Hep B, Hep C, HIV, they were all negative. I'll pause here because this is quite a big load for us to discuss.
Yeah, I think Vijay, we can backtrack. We saw the EKG. There's not a lot there to really help us make progress. I kind of do an overview. The CBC here, the white count's not elevated, nothing infectious that we can ascertain from this. Chemistry wise, so I'll take the chemistry, I guess, then the rest the urine, I'll let you elaborate on. So the creatinine's elevated, which can be secondary to what's going on. You have heart failure with reduced ejection fraction, you have HFrEF, there can be intravascular volume depletion, and the creatinine could be due to pre-renal cause and also left-sided right-sided congestion around the perinephric area and vasculature, and left-sided reduced flow to the kidney, which can cause the creatinine elevation as well. It will be interesting to see if there's a baseline creatinine as well, if there's acute or acute on chronic AKI that's going on. There is a slight bili, but you can expect with right-sided congestion some congestive hepatopathy, biliary elevation, or bili elevation as well. BMP definitely is elevated, and so no questions here. UA is interesting, not a lot of signal here. The protein is not alarmingly elevated, no dysmorphic red cells or any red cells to suggest GN here. But, I'm going to turn it back to you to then comment on a few other things, especially the echo and the urine protein creatinine ratio. What do you think, Vijay?
Yeah, I think two things that are just screaming out here. I think one is the heart failure. So, like our previous suspicion, so it is just confirming that there is heart failure. But now the question is such a low ejection fraction of 23%. So, in a young female, so this is one thing that I'm thinking, what is the cause? And ECG is also not showing much of a dilated, and even echo we don't have much clues to what could be the cause. We just have a. So I just want to know if there's any RWMA or something that we have. I'll just be curious to look at some finer clues if we get some clues. That is one. And the presence of pericardial effusion. So that is something curious. So probably it is because of the component of significant congestion and RV dysfunction. So because of low EF and probably the back pressure. That is what I'm thinking. I'd just be curious to know if there is any tamponade physiology, just from management perspective, just to not miss out on anything else. Coming to the urine, so I think the protein creatinine ratio of 0.9. So I think it is not very high. So you could see it as a part of just a tubular proteinuria that you can have in this kind of significant congestion and a tubular injury that could happen. So that is, I'm just the ANA, is it very significant? I'm not very sure of the values here. So if it is, then what is the cause of? So we are just looking at the causes of the low EF. So previous creatinine is 1.35. Okay, then thank you. It's helpful. So this again is saying this is probably a CKD. So, and the creatinine levels have always been normal. So, and urine also, ultrasound also has a bilateral CKD changes. So now, so what is the cause? So, so is it the chicken or the hen first? Is the egg versus the? So is it primarily a cardiac injury, or is it a renal injury, or are both very differently happening in different points of time? So that is one more thing, because I don't expect such a long. So either it has to be a very long-standing disease for it to cause both a cardiac and a renal disease. So for a renal disease, so probably what would be the renal disease? I'm thinking a cardiorenal syndrome, probably a chronic cardiorenal. Given that there is no frank glomerulopathy or anything of that sort, that is very striking. So how would we proceed here? So there are two things. So one is definitely decongestion, because we are not seeing much of a liver disease. So definitely decongestion, and maybe we can use ultrasound guided or something to help for it. I'm just curious, why is the thrombocytopenia there, the mild thrombocytopenia? So although ANA is negative, so how would we proceed here? Another thing, one is whenever we have a mitral regurgitation, so it is always the EF is maybe 10 to 20% more than what is there because of a chronic volume overload. So there is significant return of blood. So thereby, so we can consider the normal EF in a MR to be somewhere about 60%. So given that it is 23%, so the patient has a very significant LV dysfunction. So how it would be is to look at a cardiac MRI. to say if we could. And one more thing in the back of my mind is long-standing hypertension. So there is a small subset of like 20% of patient with a HCM, because we have hypertension, hypertrophic cardiomyopathy, that can come out or present as a burnt out DCM. So in 10 or 20%. So maybe we miss the time window and patient has developed in a DCM kind of a presentation at this point of time. So this is one more thing that I'm thinking of. And this anemia, probably anemia of chronic inflammation, it looks like normocytic anemia, renal versus cardiac. So these are my thoughts. So, and one more thing is, Ravi, do you think renal biopsy would be helpful here? So I'm not really sure. Should
Yeah.
we add center of gravity to that at this point of time?
I think the kidney is suffering secondary to the heart. I think the creatinine is elevated previously. The urinalysis is not shedding much light. The urine what do you call it? Urine protein creatinine ratio is not alarmingly abnormal. So here I'm not really seeing a lot of evidence with the kidney here itself. Mild albuminuria, I think the serum albumin was slightly low, so not terribly low. So I think the idea maybe what you've mentioning is to look at the heart itself. The heart has some complex developing or something that may have resulted in this. Even the mitral regurgitation, I mean, long-standing mitral regurgitation could develop into a dilated cardiomyopathy. Why would the mitral valve have this condition? I'm not sure at this point. But with any HFrEF, the first order of business is to determine is this ischemic or non-ischemic. And then if there is some sort of condition, getting a cardiac MRI biopsy, is that something important? Let's look at inflammation as a potential cause. So looking at the SED rate here, I'm trying to find the SED rate. I think it was 39. So it's kind of elevated. It's not alarmingly elevated where you start thinking of vasculitis maybe causing something like this. You have to start thinking of conditions that may in early age cause something like this. So we have myocarditis, giant cell myocarditis. Usually giant cell myocarditis will present with electrical storm, which we don't have here in a young patient, right? This is the optimal kind of epidemiology for a condition like that. Lupus, the ANA wasn't that elevated. There's some pericarditis. So serositis would be a downstream effect of lupus. We don't even have that kind of ANA, and then the double-stranded double-stranded DNA and so on. The antibodies were negative. So at this point, I think what is key here, decongest, get the patient better, and then solve the problem. Right now, I don't know what the problem is, but we know what the problem is, but I don't know what the solution is at this point. But optimally, the decongesting the patient, then doing further investigations will help. Any other ideas, Vijay, before we turn it back over to Eugene?
I think I would agree with this. So just decongestion and maybe look at the secondary cause once the patient is stabilized.
Okay, Eugene, take it away.
Yeah, absolutely. So this was I don't know how to put it, but there was a dilemma here as to what is actually causing this patient's heart failure. Is it the hypertension? Because there were so many multiple risk factors. The fact that this patient has a high parity, the fact that she's been having gestational hypertension, and the fact that she probably might have been having an underlying chronic hypertension. We're just looking at what really is going on. But something happened on day 4. I would add that information and then I'll review the final diagnosis. So on day 4 of her admission, the patient developed a new onset of localized swelling, erythema, warmth, and tenderness over the right lower leg. This was not associated with chills or rigors. When we examined, there was an ill-defined area of erythema and warmth over the anterior right shin. There was tenderness on palpitation, but there was no crepitus. There were no ulcerations, blistering, or necrosis. Then the pitting edema, I mean, at this point, we had given some furosemide. We started with 80 stat and we continued with 40 BD. The pitting edema had resolved slightly, but at the right side was very tense. So we went ahead to do Doppler ultrasounds of both legs. However, there was no DVT. The new CBC showed elevated white cell counts, 13.2. and the neutrophils was 85.5%, so it was neutrophilic predominant. ESR had moved a bit up to 46, CRP was 88. We took blood cultures till today. I've not had the results for that, but we started some empiric antibiotics for this patient. We continue with the furosemide. I will just pause if you have any thoughts, and then I'll review the final diagnosis. Yeah.
Very interesting development. What do you think, Vijay, at this point? Red leg.
Yeah, so there are two things that is going on in my mind. So when the patient has this amount of congestion, so sometimes you could have just because of a venous pressure, you could have some rashes that can happen. But however, the pain, some patients can develop pain, but the patient unilateral pain with a negative DVT, so the possibility of a cellulitis becomes very high in the differential. The patient is being in the hospital setting, so the organism also would be probably a hospital-acquired organism that I would think of. And we have evidence of the patient also having increasing acute inflammation in the form of increasing counts and ESR or CRP. But so this is what I'm thinking, new onset swelling, erythema, warm tenderness. So this is what I'm thinking of, it is as a cellulitis. Other thing is DVT. So maybe one more thing is I would do a serial evaluation, because sometimes you could have a DVT and maybe there could be an embolism, and thereby it could be dislodged at the point when we are checking. So there is a caveat that we have to remember, that whenever we are checking for a DVT, it could be that there is dislodgement and we may have it negative. So that is one more thing in the back of my mind. So maybe serial imaging at that is one more thing I'm thinking of. But however, I'm not very sure if how would this cellulitis help us in the diagnosis. Other thing is fevers. I don't see anything. So no inflammation, no chronic inflammation. So other thing is, so young patient, no heart blocks. I'm just thinking of secondary cause like a sarcoid, maybe some skin and heart involvement. I'm just thinking of systemic causes, although the history is acute. So these are things that I'm thinking of. I'm not really sure of what it could be, whether the skin is related to the underlying disease itself. What are your thoughts, Ravi? I'm not really sure what is the final diagnosis of what is the cause here.
So just listening to you, it's wonderful to hear you trying to solve through. Okay, you got this red leg. DVT is a great thought to rule out. I mean, that could be a sequelae of long-term hospitalization, right? So we can imagine this patient being in the hospital, and it's a unfortunate complication if patient isn't on DVT prophylaxis. Cellulitis, definitely. You talked about pseudocellulitis. Stasis dermatitis is common, but it's both legs. So I do still see this antibiotics given for patient having bilateral red legs, but it's usually stasis dermatitis. Unilateral, yeah, cellulitis is a great thought. How would that have developed? We talked about swollen legs, the superficial skin can excoriate, underlying dermis is prone to having infection then because of the exposed skin. So it's not uncommon to see that with chronically swollen legs. And that could make the most sense. You know, there was this kind of flavor of, we were talking about connective tissue disease, 40-year-old patient. Could this be a signal of a downstream effect of connective tissue disease? Somebody in the chat mentioned erythema nodosum. I'm like, hey, I think Laura had put, oh, what about erythema nodosum? And connecting that to connective tissue disease. You mentioned sarcoid, right? Great. Young person, sarcoid infiltrative cardiomyopathy. Could that be a cause? Usually sarcoid has a predominance for the lungs, so we don't hear anything of the lungs. I think it's 90% will have some sort of hilar lymphadenopathy and so on. So we're not getting that, but I would put that on my list of possible differentials. Erythema nodosum, what else? We don't get a signal. What else do we see? Bowel disease. So is this patient having intestinal issues? No. And is there association with other connective tissue disease? I'm not sure. Picture looking at it would be helpful, but now I'm kind of deviate away from that, and I'm thinking cellulitis and this. I don't know, but I still have a question mark. Is there a connective tissue disease behind the scenes causing this? Somebody also, I guess the chat does mention, can this be a reflection of like endocarditis, which could be, yeah, you could have systemic left-sided emboli to certain organs. You can get myocardic aneurysms, abscesses all over, and right-sided, you get septic pulmonary emboli. So that could be a reason as well. But I'll land my plane now because we can theoreticize on so many causes. But very interesting case, Eugene, and really well presented. It's just so amazing. Back to you, Eugene.
Yeah, thank you very much, Dr. Ravi. So yeah, this case, it was a while back since we saw this patient in an academic hospital actually. So there were a lot of theories, and I'm actually happy that you've mentioned majority of these theories that we're having. But we actually had to pause at a point, and we said, look, we have the echo findings and we have the history. We know how this patient's symptoms progressed, how it started, what she went through when she started the medication, why she stopped, and all of that. So we just pieced this information together, and we said that this patient actually had a postpartum cardiomyopathy with severe left ventricular systolic dysfunction and decompensated heart failure. We also thought that this patient had chronic kidney disease. At the time, I mean, there was no reason to do a biopsy, but one of our consultants thought that to be very sure that what is actually causing this chronic kidney disease. In fact, we did the ANAs, the DSA, all these were normal. The labs we were doing also didn't really point to a glomerulonephritis picture. So although it wasn't indicated, they went ahead to do a kidney biopsy, which showed arteriolar hyalinosis and intimal thickening and some glomerulosclerosis involving less than 20% of the glomeruli. So we thought that was hypertensive nephrosclerosis. And then we also had a right leg cellulitis. So we put a patient on appropriate medications, and the patient got better. In fact, this biopsy was done when the patient came for like a routine checkup. So before we could actually piece it together to see that the chronic kidney disease was from hypertensive nephrosclerosis. So yeah, this was a case of postpartum cardiomyopathy with severe left ventricular systolic dysfunction. And what I learned out of this case, in fact, the first hurdle is that how is a patient who is in a decompensated state not in overt respiratory distress? So, I mean, I've got to know that the body is such an amazing machine that it can actually, if the fluid overload is gradual, there won't be any overt hypoxia. And ascites will not also equate to overt hypoxia. And to diagnose PPCM, which is a diagnosis of exclusion, in fact, we're able to this patient is having a risk factor of she's got the 5/5. She also has had frequent she's also had frequent gestational hypertensions in her previous pregnancy. In fact, all the 5 pregnancies, and her hypertension was within 130s, 140. So why we didn't equate it to a hypertensive heart disease is because that usually may come with diastolic, heart failure with preserved ejection fraction, diastolic issues, but this time was with reduced ejection fraction. So we thought we should point it down to a postpartum cardiomyopathy because it was just within 11 months that this patient began to develop the symptoms. So yeah, that's where we ended up with this case, and the patient got better after treatment. Thank you very much, everybody that tuned in, and for Dr. Ravi and Vijay for the wonderful discussions.
Wow, Eugene, you presented the leg cellulitis when it's actually cellulitis. So we're trying to figure out the leg and the cardiac renal complex. So amazing. I definitely have learned a lot from your case. I will be reading in depth more about peripartum cardiomyopathy, and this was such a great adventure. Any reflections, Vijay, on this case?
I think it was perfectly presented. Keeping our thoughts till the end, you just kept us curious of what is the diagnosis. I think masterfully presented. So I think it is common, things are always common. So I think that is always that we keep in mind the pretest probability. So that is one thing that I always take back. I'm sure like the other thing is to always see how the patient does after you ensure a guideline directed medical therapy. Very crucial thing in just the DDMT that I keep seeing often is patient get a single dose of drug and there is no up titration that happens. So that is one thing. And just reflecting back on the chloride. So I think recently there are some papers that have shown more than sodium, the chloride is a better marker of adverse prognosis in heart failure. There's few papers that have come up on that as well. But I think I think I'll definitely take a deep dive into peripartum cardiomyopathy. I just remember a few bits and pieces of bromocriptine being used in between for the treatment as well, if it is refractory to DDMT in this case. So wonderful case. Thank you for presenting it. And I think we had this issue of whether should be biopsy, should be not biopsy. I think it was wonderful to just like to do a cognitive autopsy at that point of time. It was maybe tempting and not tempting to go for a biopsy or not. So maybe I think all of the pictures suggestive of not something primary renal. I think this the take home is it could be multiple things. I think keeping it how the history goes and the pretest probability how it goes. I think that is the major takeaway for me.
Thank you,
Thank you for
Vijay.
the wonderful presentation, Eugene, and over to Minahil for the teaching points.
Thank you, Eugene, for bringing such a wonderful case and amazing discussion by both of you, Dr. Ravi and Vijay. So I will start with the spelling. So first of pathophysiology, it's mainly due to venous congestion, or there can be an imbalance between the hydrostatic and the oncotic pressure. The site of swelling is very important, play a very important role, like whether it's unilateral or bilateral. Unilateral is like mostly due to the local obstruction that can be DVT, cellulitis, lymphatic obstruction. And bilateral are usually due to the systemic causes that can be cardiac, renal, or some medications like amlodipine, sarcoidosis, or SLE. So here patient have the lower lip swelling. So we have to think of the cardiac cause, liver or renal cause, or due to any medication. Then for the abdominal distension, we have to consider about any solid, liquid, or gas. Then that sacral edema is like they are very sensitive sign of for the diagnosis of anasarca. And we also have to see that how is the patient mobile or immobile? Do the patient have any prothrombotic risk? Then we discuss about the heart failure and pseudo heart failure. So heart failure, like we will find JVP, S3, and BNP compared to the pseudo heart failure, like whether patient will have the signs of the heart failure, but cardiac function will be normal. So echo will play an important role to differentiate between these two. Here patient have the facial puffiness that can be due to nephrotic syndrome, it can be due to hypothyroidism, SPC syndrome, allergic reaction, and here we have to do the urine screening that will help out to rule out the causes more. Then heart failure, the mechanism is like there is a sympathetic overdrive that worsens the heart failure over time. So we will give the beta blocker that will blunt this maladaptive response. And like S3, this patient have, which can lead to the MR, which can lead to the left heart failure and pulmonary edema, leading to those patient's symptoms. If the patient have the elevated creatinine, so that there can be three major groups where we can divide. It can be renal due to hypoperfusion to the kidneys. It can be intrinsic, that can be acute tubular necrosis, glomerulonephritis. It can be post-renal, that can be due to any obstruction. And then we discuss about cardiac renal interactions, that like cardiac and renal injuries are very, very interdependent, or it can be like dysfunction in one organ is precipitating or exacerbating the injury of the other organ, or it can be like a sign of an inflammatory process like SLE, sarcoidosis going in the body. So that's my teaching point, and thank you very much.
Well, thank you, Manal. That was great. You got all the pertinent points. All right, thank you everybody for joining. We're a little over time. and hope all of you had a wonderful hour of power. See you tomorrow. Take care. Happy Tuesday. Bye.